Good evening. My name is Chris Pelt. I'm going to be the moderator for this session of the Park City Hip and Knee Symposium 2020. The topic of tonight's session is practice management. And I think we have an amazing group of panelists that are going to give their perspective on a wide variety of concepts and topics for success in the area of joint replacement care, and how to manage a practice and be successful in caring for our patients and business value and strategies to improve outcomes. For the first session, these are 8-minute talks. We have a wonderful group of panelists, including Dr. Tom Bradbury. Tom is going to start off with his first talk, the topic being patient optimization for total joint arthroplasty. With that, I'd like to invite Tom to take over.
Chris, thank you and welcome everybody. Looking forward to tonight's session. I think we've got some great stuff to talk about. I'm Tom Bradbury. I practice at Emory in Atlanta. And I'm going to talk about pre-surgery optimization. And I think this is a incredibly important topic that we continue to get more information on in regards to best practices. And like it or not, I think we're all going to be held accountable for this type of medicine. And so I think it's fair to say it's impossible to address this topic in 8 minutes, but I'm going to do my best. These are my disclosures. They have nothing to do with the content of tonight's talk. So this study was published by the guys at Arkansas about 2 years ago. And I think it underscores kind of where we all stand with this. They looked at early revision hip and knee cases that were referred to their center over a 2-year period. And they had, I think, about 75 patients that were referred for early failure of hip or knee arthroplasty. And they did an analysis of those patients and looked at their candidacy for surgery, specifically looking at 4 disease processes: uncontrolled diabetes, and they defined that as a hemoglobin A1C greater than 8. They defined obesity as a BMI greater than 40. They defined poor dentition as someone who has not been seen by a dentist within a year, or who had obvious dental decay, and then folks that were actively smoking at the time of their revision surgery. And when they looked at those risk factors in the group of people that failed their initial hip or knee replacement surgery, 40% had one of those modifiable risk factors. And the take-home point behind the study was there's room for improvement for what we do on the front end, because what we do to prevent these complications is way more important than the way we treat them. So I think it's an important thing to discuss, and it always reminds me of this slide: losing. If at first you don't succeed, failure may be your style. And I think the way to avoid that is to be aware of candidacy issues and address them aggressively. This study was published by Rand Schwarzkopf about 10 years ago, and it sort of highlighted the idea that we all use for medical clearance. And I think most of us in our practice have some form of this, where we'll see a patient in clinic, we deem that they're a candidate for surgery, and we want to make sure their medical comorbidities are optimized. So we send them to their primary care doctor and ask their primary care doctor to fill out a sheet that ranks their clearance or ranks their risk on a scale of 1 to 5. 1 being they're optimized, they have no medical problems, and they're low risk, whereas 5 would be a very high risk candidate with multiple medical comorbidities. And they also compared this group of patients with the American Society of Anesthesiologists score, which is sort of a similar breakdown: 1 to 5, 1 being completely healthy, 5 being not healthy enough to tolerate anesthesia. And then they tried to correlate that preoperative assessment to postoperative correlations and see if they could draw any conclusions about how predictive these rating scales are. And the bottom line was these classification systems were not at all useful for predicting fairly important and relatively common postoperative complications, including pneumonia, PE, myocardial infarction, and then what we all fear a lot, wound drainage and wound infection. The only thing that correlated with higher levels of risk and ASA score was UTI. So of those 6 major post-op complications, I would argue that a UTI is probably the one that you would be most tolerant of. So I'm not sure that some of our current practices are very effective in optimizing our patients. This study was published at a Yale, New Haven, actually this year, and it's a pretty interesting study, and it's sort of a kind of a pilot study looking at the effect of an algorithm to identify, intervene, improve, and then proceed with surgery. And it's a little bit complicated, but they did a pretty thorough job of looking at 16 modifiable risks. And I think it's important to understand that there are some risks that are not modifiable. And for those risks, we need to counsel our patients that this is not something that we can improve, but you need to know this going into surgery, that your history of previous surgery on the knee or your history of whatever is going to add risk. It is what it is. We can't do anything about it. And you got to make a decision whether or not those risks are tolerable to you. But the modifiable risk factors are where we can really make a difference. And you look at this list of 16, you think about managing all these and every preoperative patient you see, it's a little bit daunting. Sort of reminds me of Jim Carrey's reaction in Dumb and Dumber. I'm not sure if my video is going to play, but when you stack all these odds against you, and you wonder if you even have a chance for success. But the basic algorithm here was on the left side of the screen, and basically it involved a nurse navigator. And I don't know how many of you guys have this in your practice, but I think it's an incredibly valuable part of keeping folks safe. So you see them in clinic, you say you're a candidate for hip or knee replacement surgery, but we want to make sure your risks are optimized before we proceed. The nurse navigator takes over. The patient fills out screening questionnaires to identify those 16 modifiable risk factors that we looked at. Each of those risk factors has a pre-programmed intervention. When that intervention is successful and the endpoint of that intervention is obtained, then the patient moves into the ready to schedule surgery bucket. They go through surgery. And so what they did was they looked at an initial 100 patients that they put through this optimization algorithm and compared them to a historical control cohort and a separate cohort that did not go through the optimization protocol. And it's no surprise that all the variables that they looked at were in favor of, a regimented optimization program. The patients that were in the optimization cohort had a shorter length of stay. They had a reduction in ED visits. They had less readmissions, and a higher percentage of them were discharged to home as opposed to a subacute care facility. So in 8 minutes, it's impossible to address all those issues. So I figured we'd identify 3 that we commonly see and talk about those for a minute in terms of making these specific modifiable risks less of a problem, specifically smoking, preoperative opioid use, and diabetes. So Brian Springer published this at an ACA Symposium a couple of years ago, and I think it's a good article to read about nicotine. And I think all of us are a little bit variable with our practice with this, but I think it's also fair to say that it is a best practice not to operate on someone and provide them with the option for hip or knee replacement surgery if they're smoking. Nicotine's addiction profile is very similar to cocaine and very similar to heroin, so it's a difficult problem to address. The best current options to help someone stop smoking are weekly face-to-face behavioral interventions. Obviously, this isn't easy. It takes a well-organized structure to get it accomplished. And then nicotine replacement therapy, i.e. smokeless nicotine replacement. Best data suggests that 4 to 6 weeks of cessation prior to surgery is the best practice, and that screening with a serum cotinine level less than 10 is commensurate with someone who is not smoking and at low risk for complications. So take-home points with smoking. Opioids, it's frightening to consider that about 1/3 of all people that are considering elective surgery are chronic opioid users. We published a study this year looking at the diagnosis of opioid use disorder, which is a little bit more of a severe issue than regular opioid use. But our study indicated that folks with opioid use disorders, no surprise, had a dramatic increase in length of stay, non-home discharge, 90-day readmission, and cost, both on the inpatient side and the postoperative side. But it's nice to know that you can intervene. And so if you're able to get a patient to reduce their preoperative opioid requirements by 50%, those patients will typically have similar outcomes to opioid naive patients. And so it's pretty simple. You put them on a tapering protocol and you say, when you get down to 50% of what you were taking before, we'll move forward. It makes them focus on that issue. And then lastly, diabetes. If you look at the literature, it's hard to distinguish what hemoglobin A1C level is most predictive of a complication. The guys in Philadelphia, including Jay Parvizi, published a study several years ago. And for me, this was really a practice-changing article. Serum fructosamine is a 2-week glycemic index. So you could have a hemoglobin A1C of 10. You could get your sugars down below 140 for a 2-week period, at which point your serum fructosamine would drop to a level that's appropriate. And the cutoff level in their study was 292. And with a serum fructosamine cutoff level of 292, they had better data and prediction of adverse outcomes than hemoglobin A1C. So it's in every single lab. It's cheap, it's readily available, and it's something that I would recommend that you consider doing. I will tell you that most endocrinologists and diabetologists do not know about this assay. So you'll send them, your poor patient will sit for 6 months trying to get their A1C down below whatever whatever level, 7 or 8, when you can really do it in 2 weeks and get their glycemic control under better order and proceed with surgery safely. Thank you.
That's great, Tom. Thanks for those very succinct 3 points at the end. It's really good to have something that we could put our hands around and make a change, perhaps. So next, we're going to move to Dr. Keith Berend at Joint Implant Surgeon, New Albany, Ohio. Dr. Berend's going to be talking to us about his experience of 10,000 and probably more than that now outpatient joint replacements done at the surgical center and how to do that safely. Go ahead, Keith.
Hey, great. Thanks, Chris. And reasonable segue into bringing all those patients that we worry about, length of stay, et cetera, into the outpatient space to keep them from even having to go to the hospital at all. So importantly, one of my disclosures that I'm going to reach or touch upon at the end of this talk is with Surgery Center Development. I am a development partner in surgery centers around the country. But what we're going to talk about today is that we reached a milestone in August of doing the 10,000th outpatient total joint at our freestanding ambulatory surgery center in New Albany. And that was the first freestanding center in the country to have done 10,000 outpatient joints. Clearly, Rich Berger led the way in doing outpatient joint replacements. He's been doing it for way longer than we have. He's done more than 10,000 way before we did. But the overwhelming majority of the first 10,000 that he did were at a hospital. And they were done early in the morning. They were done in the special care area. They were treated differently than the other patients. And what I'd like to touch on is just what our experience has been and what our research has looked at and published upon in our adventure towards doing 10,000 outpatient joint replacements. So if we look at our cohort, we reached the 10,000 mark in the middle of August, and this is our 10,100 hip, knee, and shoulder arthroplasties, 2,800 partial knees, 4,000 primary total knees, almost 220 revision total knees and revision total hips, almost 3,000 primary total hips, and 80 shoulder arthroplasties. Of all these, and Mike and Jason are going to talk a little bit about this as well, but of all these, 96% were discharged the same day. We have a 0.25 transfer rate to acute care hospital, or 25 out of 10,000, and 4% stayed overnight over the 7-year period of collection of this data. Of these, about 1.5% stayed for convenience, and 2 3/4 stayed because of a medical reason. And Mike is going to get into that. What I would like to do is present to you a little bit of the data that we've published thus far, looking at this 10,000 patient or 10,000 case cohort. The first is a study that we published in BJJ in 2018, just looking at total hip replacement as an outpatient at a freestanding ambulatory surgery center. At that time, we looked at 1,400 total hips in 1,200 patients, and we had a 6% overnight stay rate, and half of those stayed for medical reasons. The important part of that was 0.3% had a major complication within 48 hours. A major complication was defined as surgical or medical. Even more important was a 2.2% 90-day complication rate. That is 1/4 the rate that Tom Bradbury presented stuff that came out of Arkansas, where they looked at doing a optimization program and bundled program, and they had reduced their rate down to 8%. Well, our 90-day complication rate was 2.2%, which is incredibly low. And yes, some of these patients are optimized. Some of these patients are picked out of the litter in order to succeed. And Mike and Jason are going to talk a little bit about that. One of the interesting subjects, and this is a paper that we just published, we looked at our morbidly obese patients. And by morbidly obese, this is defined as patients with a BMI of over 40. And so of the roughly 6,000 patients that we looked at, 4,800 were in the non-obese patient population, and 1,100 were in the morbidly obese population. And if you look at the preoperative demographics, you can see some clear examples of where they differed. You would expect that the morbidly obese patient would have more obstructive sleep apnea. Absolutely, almost 3 times as much. COPD, asthma, and the rate of any comorbidity was 50% versus 64%. So then we looked at what were the outcomes that occurred with these patients with morbid obesity, which a lot of us would have thought would be a contraindication to having an outpatient surgery. When we first started looking at outpatient surgery in Columbus, all of the surgery centers had a cutoff of 40 BMI. So you could not operate on a patient if they had a BMI of over 40, even if you were doing an arthroscopy. We're talking about doing total hips and total knees and total shoulders in these patients. When we looked at the reasons for overnight stays, and so a lot of states allow you to stay overnight, some states don't. And so if you're considering outpatient joint replacement at a freestanding ambulatory surgery center, if your state does not allow overnight stay or 23-hour admit, then you need to look for things like obstructive sleep apnea, respiratory or asthma problems as indications that you have a very increased risk of having to stay overnight. And those are pretty easy to identify. Other than that, cardiac history, arrhythmia history, difficulty ambulating, there were no other reasons that patients had to stay overnight other than a pre-existing problem with obstructive sleep apnea or asthma or respiratory problems, which is pretty interesting. That means you can operate on every obese patient in the ambulatory surgery center, even if you can't keep them overnight, as long as they don't have a respiratory or sleep apnea problem. When we looked at the overall complication rate, and this got cut off just a little bit here, and I apologize for that, there was no difference in any rate of significant complication between the obese patient and the non-obese patient, including medical event within 90 days, revision surgery or any surgery within 90 days, and importantly, periprosthetic joint infection, no difference in the obese patients. And so these are morbidly obese patients, so BMI of over 40, to where there was no difference in any complication out to 90 days in patients that were done as an outpatient versus those patients that were not morbidly obese. It really broadens the horizon in terms of making sure you have a medically optimized patient, which Tom Bradbury talked about and Jason's going to talk about. Obesity can be taken off that list of reasons why you wouldn't offer someone the benefits of having an outpatient procedure. One of the other things I wanted to just briefly mention was our recent study looking at outpatient revisions. And so you look at the complexity of doing revision knee arthroplasty, and most of these were poly changes, as I'll show you, but many of them were not. Many of them were femoral revisions or both-sided revisions. Some involved cones, some involved constraint. If you look at our overall population between 2013 and 2018, we did 106 revisions of total knees in the surgery center. That's about 2% of the arthroplasties done at the ASC. So 1 in 50 were a revision. It's 8% of the revisions that we did as a practice, which is kind of interesting to think about. The demographics, as you can see here, were age range, young to old, weight, thin to heavy, etc. The important thing to me is we consider revision arthroplasty to be this dangerous, scary, horrible thing. We had no major complications within 48 hours. We had 1 ER visit and 1 readmission in 11 days for the treatment of ileus, no deaths and no surgical complications or any reoperation within 90 days of over 100 revision total knees that we did as an outpatient. So I think the bottom line is that this is a scalable and applicable way to get into outpatient surgery. We were involved with surgery center development with our surgery centers. I'm involved as a developer. We started our center in 2013. Between when we started and today, Surgery Center Development has over 220 facilities in 21 states. They have a standardized yet local surgeon modifiable program. They've done over 55,000 outpatient joint replacements. If you do the math, that means we've done almost 20% of them at White Fence. The length of stay from leaving phase one of post-op PACU to leaving the facility averages 4 hours. So when we talk about these studies of reduced length of stay, I'd like to see reduce the length of stay below 4 hours, not 2.5 days or 3 days or whatever. 97% of patients go home the same day. There's a 0.4% readmission rate within 48 hours. And there's a 0.25 combined percent infection rate across all arthroplasty procedures. And that's over 55,000 joint replacements done. I think the ultimate grade card, though, is how do the patients feel about it? And since we opened 7 years ago, in 2013, we have a 98% good to excellent satisfaction rate. With our program that we use for patient outreach, we get almost 90 to 95% patient engagement with giving us back our patient satisfaction scores. And patients are incredibly happy with this level of care. It's intimate, it's patient-oriented, it's surgeon-oriented, and clearly the data shows with over 10,000 cases, it's safe and it's the best way to go forward with outpatient joint replacement care. Thank you.
Thanks, Keith. Great talk, and awesome for us to hear how you can be successful in the surgical center environment. Jason Hurst, also a partner at Joint Implant Surgeons and participating in that same program, is going to talk to us a little bit more about this and the pre-screening of patients for outpatient success. How do we do this successfully? Go ahead, Jason. Thanks so much.
Hi, guys. So I'm going to talk about this pre-screening, and I'm not going to get into some of the a lot of the medical data that we have. I'm just going to kind of tell you how we did it, and then I'm going to talk about it from two different perspectives. One is the medical perspective on how we pre-screen our patients from a medical standpoint, and then how we do it from, I would say, at a financial or insurance-based standpoint, because I think that's just as important in terms of the health of your center. Here are my disclosure slide. So if you ask us, as you can tell by our enthusiasm for outpatients, we would probably like to say that every patient has the potential to go home the same day. Just got to find those patients, or maybe select those that can't. And when selecting the patients, I think the criteria that must be met is, of course, they have to be a healthy patient. And the most important thing is that everyone's going to have comorbidities. They just have to be well managed. They have to have a well-engaged family as well, so that they do have help when they come home. They have to be safe with ambulation. They don't have to be perfect, but they should be safe. And then you have to have a protocol that's ironclad with respect to anesthesia, pain control, and post-op communication. That's really, really important, that the center is involved in that communication and your office is just as much. So this is our kind of, I would call this our health screening algorithm. It's very simple. We have discussed this at other meetings as the system failure method, meaning if the patient has a failing organ system, that patient cannot be done as an outpatient. So the first question you need to ask is, does the patient have ongoing medical issues that cannot be optimized? If the answer is yes, that they cannot be optimized, you got to postpone them until they're medically optimized. But if they are optimized, you have to ask yourself then, if they are at optimum, do they currently have an organ system that's failing? If the answer is yes, you stop right there. And anything you can think of with respect to organ failure, cardiac, pulmonary failure, are they having a hematologic failure? Then they probably aren't appropriate either. If the answer is no, then the next question is pretty simple. Do they have support? You can't send them home alone. So do they have support to get them home? If the answer is yes, they can be performed safely. Now, this might seem rather, I would say, aggressive, but our data supports this kind of algorithm. And in the beginning, though, we obviously were not like this. We had a little bit more of a cautious approach, and we kind of made this go or no go list. And we thought like that that with respect to the cardiac system, that if you had been revascularized, or if you had CHF, or you had a valve disease or arrhythmia, that you wouldn't be a good candidate. But we realized was that with respect to prior revascularization or an arrhythmia, that your comorbidity has been well treated and that they're actually stable. So those are off the list. So those in blue in this laundry list are things that we originally thought might contraindicate a patient for outpatient, but actually we realized they're not a contraindication. So those have come off the list. And as you can see by our studies, BMI over 40 is definitely not. Untreated sleep apnea, we think might be, as Keith may have just showed you. As long as they're treated, they can still go to the center as an outpatient. The one that did in our data show to be risky were those patients that were having hemoglobin below 13. And if you think about it, you can't transfuse at your center. So you want to be sure that your hemoglobins are above 13, especially in your HIP patients. And another kind of go-to point was, what about the patients who have severe BPH? Well, you just got to plan ahead. You have to know these things ahead of time. You can manage them appropriately. But the location really doesn't matter. If you have the things in place and you have, if you've said the patient is safe to go as an outpatient, whether you do them at the hospital and send them home, or do them at your center and send them home, it doesn't really matter. But what does matter are these payer factors, which I highlight here, because what you'll see is that both of these centers reimburse very differently for the same procedure. For hospitals, almost all cases are typically paid for across the board for Medicare and commercial insurance. With respect to ASCs, though, however, the payment depends heavily on that payer. Commercial insurances have contracts are negotiable. So what you'll see is that, if you look across your portfolio of insurance contracts that you have, it's a very different reimbursement for the same CPT code or DRG code. Medicare contracts are non-negotiable and are considerably less at the outpatient center. And currently today, only uni and total knee are paid for. There is no outpatient group for total hip until next year. But don't be afraid of Medicare. You can still use it. I mean, there are plenty of patients that do exist within the Medicare population that are great candidates. I mean, these patients want to go home just like anybody else. In fact, they're probably pretty disgruntled because they're older and they want to get home and they do not want to be in a hospital. You can use it to fill your day at the ASC, even though they do reimburse much less. There is still some profit there that can be had for your center. But the most important thing is that it keeps you in control of the episode of care, which I think is the most important thing as to why patients like outpatient arthroplasty better than inpatient, because the doctor's in control and we make it as good as we can for that patient. But the most important thing, and this is what I'm going to hit on, is that you must verify the benefits very early on. It's the responsibility of your practice's billing department to verify the patient's insurance coverage for that center that they're going to go to. And you have to know, are they in network? Are they out of network? Is it Medicare? Is it Medicare with some sort of secondary or a commercial Medicare product? You have to know specifically what coverage your patient has. That's what we do before every patient even sees us in the office, whether it's an operative patient or not. We have a star system. Every single patient that we see in the office has either a green star, a blue star, or a red star. A green star on their chart would say they're ASC approved. If I decide to do surgery, they can go to the ASC from a payer standpoint, not medical, from a payer standpoint. If they're blue, they are Medicare. So that's going to be quite variable based on the procedure you choose. And then if it's red, hard stop, they got a weird insurance, they cannot go to your ASC. Our old charts used to look like this. There's the big green star at the top. This is a green star patient. We love these green star patients. If they need a surgery, they're going to the center if they meet the medical criteria. So here's kind of the algorithm. You verify the benefits. You determine the coverage candidacy by the star system. You then send them to your medical doctor to be cleared. They know the algorithm from the medical perspective. And once they clear that, the next step is extremely important. The center's responsibility is to make sure the surgery that you are signing them up for is appropriate for the center from a financial standpoint, because there are some payers that should never go to your center for arthroplasty. Because like I said before, a lot of these contracts are done beforehand and have a variable pay rate compared to others. So for example, some insurance companies might not pay you well enough to even cover the implants and all the things they need to do to a patient, and it's a total loss. So that patient should not go to the center. You should not do your total femurs at your center because the cost will be too high. So it's really important to realize that some of these centers that may have been long-standing have older contracts which do not include arthroplasty and may not be good candidates for your center. However, some might be excellent. And that's the most important way to figure this out. And it's the center's responsibility to figure that out for you. So to summarize, outpatient arthroplasty, it actually does reduce healthcare costs, despite the fact that we're talking about profit. We know Medicare pays less. Overall, to the system, it's a less of a burden on the system if they go as an outpatient because it's less expenditure. We know that we have better control there. There are better outcomes. Everybody's happier. And I believe that the appropriate compensation to the surgeon is definitely justified because of the increased risk that we undertake as the surgeon taking care of the patient. Way more than the hospital who used to take most of that profit. And lastly, I will say that when selecting the appropriate patients, it's not just those medical criteria. You have to look at the financial criteria, including the coverage, because it's just as important for the viability of your center and your practice's success as well. Thanks.
Great talk, Jason. Thanks so much. We're going to stick with the joint implant surgeons team. We're just a few minutes behind, but these guys, they get it and they do a lot of this. So Mike Morris now, also out of New Albany, Ohio, is going to talk to us a little bit more about outpatient complications that Keith alluded to earlier. Thanks, Mike.
Thanks, Chris, and thanks to the Park City Hip and Knee Foundation for the invitation, as well as the sponsors. So they should be recognized as well. So, I think we have a pretty good system in place. However, we're not perfect, and outpatient complications can still occur. So we're going to touch on our experience. These are my disclosures. None of these are pertinent to this particular talk. However, I am a surgeon owner in White Fence as well as Southeast Ohio Surgical Center. So that should be on here as well. I'll air some of my own dirty laundry. So here's a gentleman that came to me. Both hips are bad. Plan to do them both. Pretty straightforward. First one goes swimmingly. He does awesome. 6 weeks later, I crack his femur intra-op. And you got to be prepared for this. This is my bad. I put a cable on it, protected his weight. He healed and got him back to work, and he's happy. However, you got to be prepared for things happening occasionally. As Keith mentioned, we are an independent, standalone ambulatory care center, and that's important. Many of you might be working at tertiary care centers. You might have access to cardiac cath labs, dialysis, ICUs. Some of you might be at non-tertiary facilities and not have those type of entities. But if you're going to be doing outpatient arthroplasty or outpatient any type of procedure, you need to have a plan in place if something happens, especially something medically. So you need to have those relationships established. So Keith touched on this, our experience with our first 10,000, about 4% stayed overnight. Portion of those stayed for convenience, 1.4%, and 2.75% stayed for a medical indication. Most commonly, the indication to stay overnight, if you're a man, it's urinary retention. If you're a woman, it's nausea and vomiting. Also, sleep apnea precautions for those that have sleep apnea or high risk for sleep apnea that are untreated. Precautions should be taken in those patients. Folks that are on CPAP and that are compliant are much less of a concern, and those folks can go home. And hypoxia is the other major issue post-op that kept people overnight. Importantly, there was 25 patients transferred to a higher level of care. We're going to talk a little bit more in detail about those, what those etiologies were. So 4 demonstrated symptoms of a stroke. Those were all transferred. 1 had an intra-op cardiac arrest. 4 had AFib. 5 patients actually had EKG changes, and the concern was for MI. Sent onward, and MI ruled out in all 5 actually. Some had some pulmonary issue with DSATs that were unable to be remedied at the center. Jason had mentioned we don't have the ability to transfuse a patient. There's 1 patient that we had to send over to our other hospital to get transfused. 2 patients had allergic reactions. 1 patient, uncontrolled nausea and vomiting, actually wound up with an ileus. And then 2 patients had falls requiring surgery. There were 10 additional transfers that occurred before any surgical intervention. These are people, as an example, showing up to the facility in new onset AFib. had significant DSATs on induction or something like that, that necessitated cancellation of the surgery and transfer out to a tertiary facility. So if we look at our 7+ year experience and we look at the percentage of folks that either needed transfer or needed to stay overnight, you see that we peaked at around 6% in 2015. It's been decreasing since. The last 3 years have been pretty constant. Interestingly enough, in 2020, we're down to just around 0.5%. I don't know if that is COVID related. I mean, it's amazing. It's very hard to convince anyone to stay overnight anymore. And we're doing a lot more Medicare knees now. So whether or not that's going to hold in 21, it'll be interesting to see that data, but that's dropped even below 0.5% now. So Keith and Jason had alluded, are we just doing the chip shots? Are we just doing those folks that are just the best candidates possible? And the answer to that is no. And you saw some of the obesity data, and that might be hard to believe for some of you that over 1,100 of these folks were morbidly obese with BMIs greater than 40, but about half our patients have at least one major comorbidity. And some of these are potentially scary and significant. Coronary artery disease, arrhythmias, sleep apnea, COPD, valvular issues, etc. So about half of these patients had that. It was predictive of needing to stay overnight or necessitating a transfer to a higher level of care if they had greater than one major medical comorbidity, and that was significant, 5 versus 2%. If we look, and this isn't the 10,000 that we're talking about, but this is data analyzed through the first 6,000, which was through 2017. Complications within the 48 hours was approximately 1%, including 19 that were transferred. We talked about the ones that were transferred. There's a smattering of other things. The most common things: falls, 4 in physical therapy, 3 at home. 8 patients called in with uncontrolled pain, necessitating some modifications to their pain schedules. And 10 presented to ER with VTE type symptoms. 8 of them were negative, 2 of them were positive. A smattering of other issues in the first 48 hours. Those were the bigger ones. Unplanned care after 48 hours. So these are folks after 48 hours, but within the first 90 days, it was 1.3%. And there's the list of the types of surgeries that they had. Only 2 revision cases had any unplanned care after 48 hours, interestingly enough. 13 of these had positive DVT. 11 of them had some type of allergic reaction to our closure material, which is Dermabond. There was a handful of urinary issues, either UTIs or retention, a handful of constipation issues and ileus, and then 11 cellulitis issues treated with antibiotics, and then a laundry list of one-offs that needed to be addressed. If we look at people that needed to return to the operating room within the first 90 days, it was 1.35% in the first 6,000. The majority of these folks were some wound-related issue. There was a few hematomas that needed evacuated. There was 1 2-stage for infection. The other probably major concern was 6 periprosthetic fractures in the total hip population with single blade stems. That hopefully is being remedied at the current time. We've been using a lot more triple wedge stems as well as more Mueller style stems with much better results and without seeing the periprosthetic fracture issue. Probably the big thing that's everyone's major concern is, are we harming patients? And we looked at our mortality data, and we had 4 out of the first 6,000. I'm unaware of any over the next 4,000, but that data is being analyzed currently. But of those 4, 1 happened at post-op day number 11. That was a PE on low molecular weight heparin, so being treated appropriately, and still had a PE. Day 11, 1 was day 33, cause unknown. One was day 14, which was suicide. One was day 48, cause unknown, but was seen at the 6-week appointment and doing well. So I would submit that none of those patients would have been saved by staying in the hospital. Unfortunately, mortality is not something that anyone wants, but this is our data as it's presented. I don't think any one of these, based on our evaluation, was preventable. So that's it, Chris, and I appreciate your time, and I look forward to the discussion.
Thanks a lot, Mike. Really, really great. So we're going to move on to Bill Hamilton. As I recall, Bill is a Major League Baseball fan. We don't follow it too much out here in Utah with not having anything in the majors, but the Braves are currently down 15-0 in the middle of the 3rd inning, up 2-0 in the NLCS. I don't know if Bill has any thoughts on that, but he is going to give us his thoughts on connecting with patients once we kick them out of the hospital very quickly, even though it's safe. So Bill, thanks for the talk.
Chris, really appreciate it. I have really no opinion on baseball at this point. The Washington Nationals were in last place this year, so we'll skip over that quite definitively. So I'm gonna, really good talks from New Albany, really amazing data that those guys have accomplished. I'm gonna give a little bit of a talk as part of an outpatient course that Mike Meneghini and I chair. That's a little talking about staying in touch with patients after they leave. These patients are leaving 4 hours later. So instead of being in the hospital for 2 days, we do have to keep in touch with them. And here's a few strategies. So this is a little bit longer talk that I'll condense down, trying to stay on time here. Disclosures, none of which are relevant to this topic. So I think number one critical take-home message, post-op communication is enhanced by your comprehensive pre-op education and preparation. So this includes online materials, written materials, verbal instruction, and all the counseling that your medical, PT, and case management folks can give. I will tell you one really good take-home message is make your information as consistent as possible. This is a little tidbit that will drive patients crazy. Here's an example. Here's the Anderson Clinic discharge instructions, and they say some really simple things like ice your knee every 20 minutes. You may shower in 3 days, remove your dressing in 7 days. You can drive at 4 weeks. We would agree that that's all quite reasonable, but here's instructions that come from the center, and it says you should be icing every 2 hours. It says you can shower only right as when you get home, remove the dressing in 10 days, and you can drive after 6 weeks. Well, the rational people would look at these two sets of instructions and say, those are basically equivalent. But most people who say, I have to do exactly what the doctor says, will look at these two things and say, there's discrepancies. It drives me bananas. They'll tear their hair out, and they will end up calling your office. This leads to phone calls and dissatisfaction. So the first thing I would do, proofread all of your instructions to make sure it's consistent. I don't care if you go with the one on the left or the right, but make certain that it's consistent. This will help your patients follow instructions, which many of them want to do. What about communication after the discharge? Of course, your facility nursing staff can contact them. Questionable whether we should be calling them, although that's a good idea. Then there's this question about home care or physical therapy, and when do you have your patients follow up? I'd say maybe there's a better way. This concept of mobile health, we now all have mobile phones, but there are mobile experiences that are evolving patient expectations. And we know there's a number of publications on these things that can lead to better outcomes. I'm going to skip a few of these publications to try and get through the take home. There's different ways to do this. There's one-way communication where you can send out messages via the smartphones. There's two-way, which allow patients to respond. And then there's measurement techniques. I think the folks in New Albany are doing some of this where they're measuring outcomes along the way, like measuring your steps, measuring range of motion, even GPS about what the patient's doing on a day-to-day basis. There is some data on this showing that it doesn't appear to make any difference whether you do home health or some of these digital rehab apps. This was a mobile patient engagement app that we used for several years. I can use the brand because this is now extinct and we're now on to the follow-up brand. But basically what happens here is the staff registers patients pre-op. Patients will then download the app on their phone and log in, and now they're engaged. They then get some welcome messages. Hey, welcome. Here's what you're going to do. Your medications have been sent to your pharmacy. You need to get the equipment. I want you to start some of the exercises ahead of time. Then our nurses and our staff will get a dashboard of patients. They'll be able to follow the list of patients that have had surgery recently, whether or not they've checked in, and whether or not they have these red flags, which say, okay, do they have a fever? Are their pain scores out of bounds? Are they not having a bowel movement? Whatever it might be that might trigger a red flag at that point. The patients then will have these checking questions and have their to-do tasks like the exercises. There's maybe one of the best parts about it are some of these videos that patients can follow along with. This has largely allowed us to do away with home care and home physical therapy. I don't know if this is necessary. You could probably do this via print or other resources, but the mobile videos seem to be quite helpful. This is also somewhat helpful. Patients will call up and say, you know, I'm worried about my wound. It's a little red. I'm seeing this bruising. And the patient can send in pictures that we can see directly, so we don't have to have them come in to check an app. And this is all HIPAA compliant. And you can see in this patient has a perfectly good looking leg with a dry dressing that looks pristine. And then you have somebody that has sent something in that's a little more concerning. So you're able to distinguish the concerning wound from the one that's completely normal for that time frame. And it helps to avoid some of those acute visits. This allows us to answer questions, refill medicines, and maybe most importantly, avoid phone calls. So what has using an app like this achieved? I think there are fewer phone calls. I think there's overall less mail because we don't have to send follow-up appointments. We can communicate without having to use snail mail. I think the patients in a way do feel more connected. For us, it allowed us to get rid of home care for the most part. I don't think you necessarily need an app like this to get rid of home care, but for us, it was the avenue to do so. This is not a perfect system. Instead of now answering the phone, now the nurses do spend quite a bit of time on the message board. I think the patients can overuse the app because they have accessibility. And like when you have an app, whether it's Facebook or Twitter, if you have the ability to type in a question at any hour, patients tend to do that. They also tend to get quite frustrated when they don't get a response immediately. So I often have to tell the patient, hey, listen, you can use the app, but this is really for business hours. If you have an emergency, you need to call us or call 911. So consumers are looking for this. We all know everyone's on their smartphone constantly. This is the future. How is this going to arrive? I think that remains to be seen. I do think that there is a role for this along with telehealth, and telehealth has become a part of my practice since COVID. I used to see patients 4 weeks, 4 months, 1 year, and every 5 years thereafter. I think telehealth will help to substitute for some of this, especially for some of those patients who are longer distance. People want access to telehealth for simpler visits, simple follow-up questions. I think this is applicable, especially for my people that come from a long ways away. So I think outpatient TJA, total joint replacement, is here to stay, and you've seen the data on that. But when the patients aren't in the facility, it's helpful to use modern technology to keep in touch with them. I do believe it improves patient satisfaction. Thank you very much for your attention.
It's a great talk, Bill. Thank you so much. We had one question posed in the Q&A area by Peter asking about calling our patients. I think Bill's just highlighted the fact that there's mobile technologies that may be able to do some of that work for us. The personal touch of a surgeon talking to their patient probably can't be matched, however. I'm just going to give my answer to this, and maybe I'll ask Bill real quickly. I actually call my patients on the evening of surgery. We do about 70% of our primary joint replacements as outpatients at the University of Utah now. I used to round on 100% of those patients in the hospital at the end of every operating room day to see how they were all doing. Instead of rounding on them, I now make a 38-second phone call and say, hey, how's it going? And I would say 98% of them say, hey, doc, thanks so much for the phone call. I'm doing great. I have no concerns or problems. That personal touch for me has made that post-operative rounding both A, quicker, and B, very satisfactory to both myself and my patients. Bill, Any thoughts on the personal touch of, or lack thereof with this type of technology?
Well, yeah, the technology is not entirely personal. You can communicate back and forth with the chat box and whatnot. I think people like the touches. I think people are used to that with social media. But I think your idea about the phone call is a great one. It's I think some of my mentors, the likes of Bob Booth and Dick Scott, and many of these giants in our field, but they taught me the importance of the personal touch, and I think it exhibited their level of success. I got to be honest with you, that's faded for me, so I do try to call people who I'm concerned about, or people that, sometimes I cherry pick and I call the people who I know will be easier calls for me. Those people who, when you call them, they're going to be doing great, but it's not going to be 38 seconds. And there's no way you're going to get off the phone unless you hang up with them, because the questions won't end. That is difficult. And I will admit that I haven't entirely been able to call 100% of my patients, but I think it's a great thing to do, especially early in practice as you're trying to build patient reputation.
I'm going to ask Tom Bradbury one question real quick before I move to the next panelist. What about the non-modifiable risk factors? We all see these patients. We talked about trying to optimize 3 things. I really liked that summary of 3 things we could modify. Obesity, maybe all not that modifiable actually, and many of the other things that people present to us with. And we get presented with this concept that as an adult reconstruction specialist, the procedures that we do are elective. And I don't think that many of our patients agree with that. And I'm not sure that many of us agree with that. There's extreme disability that ensues with the lack of our interventions, for example. And so,
Chris, let me say, if I could interrupt one thing, that is that our lieutenant governor stated, and our governor supported, that joint replacement is not an electable operation. It's not an elective operation. And whether you're morbidly obese or not, it is not an elective operation. Boob job, nose job, things that can be delayed without harm are definitely elective operations. Joint replacement is not. Whether Ohio is above the curve or below the curve, our governor stated that, and he was correct in that. And when it comes to obese patients, that is a modifiable risk factor. Surgery can be delayed, and home monitoring and home coaching and weight loss, losing 10% of your weight can occur healthy over 90 days. And that's not too long a period to wait to have a joint replacement.
those are great points. Well, we are at a time point where I think we should probably move to the next. Any other questions we can just have answered in that Q&A session. Our next topic is actually, again, by Dr. Hamilton, and he's going to get into pharmacogenetics, a little bit of the sciencey side of what we do, and his experience with looking at this both clinically as well as from a research perspective. So Bill, do you want to go on to the next talk?
Yeah, I'd be happy to. I think this session is going to focus on opioid management, and this is obviously really pertinent nationwide, and we're all, as we're managing the opioid epidemic, I think really important. I became interested in pharmacogenetics a few years ago, and have started studying this, and I'm in the midst of a couple prospective randomized studies, but I thought I might just introduce this topic because this might be something unique that y'all haven't heard about, because it was something that I hadn't heard about much. So first, I'd like to say I have no disclosures relevant to this topic, but pain perception is complicated. We know that there are patients, and if you go on your post-op rounds, you see them days afterwards, you'll have this first patient who says, man, I'm doing great, I got no pain. And the second one who says, man, this is the worst pain I have ever felt. And you did the exact same surgery on the 2 of these patients, and you've given them the same pain medication. So why is that? I've always been confused about this. We know that pain perception's complicated. There's many things that contribute to the perception of pain, but this concept of the genetic contribution of pain perception was one that was somewhat foreign to me, so I thought I'd share it with you. This concept of pharmacogenetics And what is pharmacogenetics? It's the study of the genetic basis of pain and the drug response. So the basic premise is you take a population of people, there's going to be some who are non-responders or have toxicity to a drug, whereas most people have a favorable response. We now know that your DNA does affect your response to drugs. And there's now a DNA test that can be done, which may be able to distinguish those who are going to respond favorably to a medicine versus those who will not respond favorably. So there's this concept of predictive prescribing, where you take the genotype, that's what your genetic code says, and it can categorize you into one of the following phenotypes. The extensive metabolizers would basically, you have normal metabolic activity, and you give someone a medication, they're going to metabolize it as would be expected and have a normal response to the drug. You're going to have those that don't metabolize as well and maybe have reduced metabolic activity. The ultra rapid metabolizer, where you have increased metabolic activity, and those that have none. It's important that you understand the difference between an active drug, which is one where you give the drug and the actual chemical that you're taking is the active medication, versus what's called a prodrug, which is what you ingest the inactive the inactive drug, and it only becomes active until it's metabolized. Here's one very popular example of this. Codeine is a prodrug. So when you take codeine, it actually has no effectiveness. There's no codeine receptor until it is changed into morphine by the CYP2D6 enzyme. These cytochrome P450 enzymes, they live in your liver. We all learned about this in medical school, but these are important enzymes. The CYP2D6 is maybe, if you had to remember any enzyme from this talk, that would be it. And it changes codeine into the active metabolite. There's been extensive research on this CYP2D6 gene. There's 80 alleles identified. And when you start to get into the research on this, you'll see that there's an extensive amount that's been published on this. So how does pharmacogenetics work? Well, first thing, you can do a cheek swab just like you would 23andMe. You collect that in the clinic and send it to the lab. You can then get this report back. This is currently not covered by insurance. This is a cash service at this point. But they'll get you this report, and basically you can see that there's drug classes. There's the green, yellow, and red columns. And it'll say, okay, this patient, all the meds in the green column are fine. Yellow, maybe not so much. And in red, there's potentially a problem. And it'll give you specific medicines. For instance, in this patient for hydrocodone, they carry 2 copies of this ORPM gene, and possibly this is going to be a problem. So you can consider using an alternative medication. And it'll give you alternatives in the green column that you might consider. So we did a study on that. We wanted to know, could this be implemented in a total joint practice? What's the incidence of genetic anomalies relevant to our standard post-op multimodal programs? And then lastly, and this is the most important but most difficult question to answer, is can we improve pain control in patients who have a genetic variant? This was phase 1 of our study that we completed over a year ago. We enrolled 50 patients, 25 standard, 25 customized. Unfortunately, as we were 2/3 of the way through the study, the FDA came and said, no, can't do this anymore. We had to abruptly stop the study, and there's been quite a bit of FDA regulation with regards to these pharmacogenetic tests. But basically, we had 2 groups, and I'll kind of go through this results because it was a small subset of patients. But basically, we had about 40% of patients who had abnormalities to one of these medicines. Here's an example. This patient was an ultra rapid metabolizer, which means you give them a medicine and they turn it into the active metabolite very quickly. And these patients can have a very good pain relief, but very significant side effects. These patients might be the ones who actually get addicted to it, these medications, because they get that sudden high. So he had pain levels for well above a 5 all week long, right after surgery. And his quote to us was, medications never last as long as they say they will. And he took more than twice the average of narcotics in the first week. Phase 2 of the study is ongoing. I've just completed enrollment of 100 patients. Once again, prospective randomized. We had to use the new lab, but we're in the process of data accumulation at this time. The summary is this is an interesting topic. I think that implementing pharmacogenetics is fairly straightforward. In our hands, this was free to the patients, so fairly easy. We were able to get access as part of the study. And they were happy to do a cheek swab. A lot of patients really bought into the concept. In the first phase of the study, we had over 40% of patients that did have a variant to one of these commonly used medications. Of course, we need a lot more data to know if there's a role for this in our practice. But I think it's a really interesting concept that has potentially a future in personalized medicine and pain control. Thank you very much.
Really exciting technology, Bill. Thanks for the update on that. This is a topic about decreasing opioids and pain management in this particular topic, the Practice Management Symposium. So with that, I want to move on to the very next discussion point, which is Jason Jennings out of Denver, Colorado, who has a unique perspective on opioid alternatives in what might be not a red state or a blue state, but a green state. Go ahead, Jason.
Well, I was asked to talk. Thanks so much for having me, Chris, and to the Park City team. Opioid alternatives, and I think he hinted towards it. They want me to talk about cannabis, and we'll cut to the chase. I have no disclosures regarding cannabis to report, but here are my other disclosures. So this is actually two of my patients in the last year. I think some of you have seen these slides. There's many more patients that come in, and there seems to be some humor to it. I would argue while there's humor, there's still a lot we don't understand. And I'm sure that many of the folks on this call, if you think about the last 5 years of your practice, I've talked to some of you that you've had multiple patients ask about it, and it becomes more and more as time has gone. So there's been a significant amount of change and legalization in different states. And this was an article that my partner, Dr. Kleeman, Dr. Dennis, and I did together for the Academy. This data may be a little outdated. This was from last year, but you can see there are certainly a lot of states that either have legal use for recreational or medicinal reasons. And as this number continues to increase, I suspect that our clinics will be overwhelmed with some of these patients. And as you'll see, I'm not really quite sure I have all the answers for you today, but I'll try to shed some more light. This is a combination of studies that have been done in looking at what exactly is available on the market from an FDA standpoint and what it's used for. And if you see, most of it's chronic pain, spasticity, but you don't really see acute pain after total knee, total hip replacement on here because it's an off-label use if it's being used at all. And what we're really talking about are two different substances. It's really the THC and the CBD, which you probably are familiar with both of them. For the purpose of this talk, it's 8 minutes. I can't get into too much detail with both of them, but I'm just going to refer to cannabis as a generalization, kind of including both. So please bear with me with that. So, you know, the state laws have changed. This article came out recently last year in the Yellow Journal looking at the cannabis use and actually correlated with a decreased amount in the opioid prescriptions. I would argue while it's a good study and a nice start, it clearly has a bias because many states have cracked down on opioid use prescriptions, and there's been things all over the news. So I think all of us in general outside of cannabis have decreased the way we use opioids. For us preoperatively, we just don't give them, and postoperatively, it's a very short period of time relative to what we used to give 5 and 10 years ago. So while the study probably has some merit, I would just take it with these laws changed at the same time some of the opioid prescribing patterns had. So about 5 or 6 years ago, this was the first study that got me into cannabis. I just looked back at our data at our institution before the law in Colorado had passed with 550 consecutive patients before the law. And then around a year after, we looked at this in 550 consecutive patients, all undergoing total joint arthroplasty. And you can see the numbers are fairly dramatic, the increase. It was 1% of people reporting some sort of marijuana or cannabis use around the time of surgery, which went up to 11%. That 11% is probably higher. There's at the time people probably not willing to report the use or afraid to report the use because the state law is different than federal law, and there's some implications that we can talk about later with regards to that. And we found risk factors of those patients who may be using, and it's really no surprise if you look at the world's literature on alcohol abuse or any substance abuse, male and young age, current smokers, history of substance abuse. I used Medicaid as a surrogate for socioeconomic status, and preoperative narcotic use, so polypharmacy is involved in these patients. This study is either in print, it is online, but it will be coming out in JOA soon. It's already accepted. But I went back and looked at patient perceptions. I always tell my fellows and people that I train is like, you might think you know what the patients want, but if you ask them, sometimes it's different. And interestingly, I just told you that 11% of people had reported use. In this study, I have about 500 patients that came in for preoperative appointments, and 20% of people are reporting current use. So there's either more people willing to report use or more people using, and that's over a 5-year period. We went up 9%. And I would argue that that 20% is probably a little higher. I'm sure there's some underreporting, as many studies would tell us in the past. But interestingly, if you look at the bottom, 75% of people said they'd be willing to use cannabis if they were given to this around the time of surgery by their doctor. And I'll get back to this because this has significance to what I'd like to share with you about a new study that I'll be doing. And interestingly, 53% of the people here had never tried cannabis, so any type of marijuana. So there are people who haven't tried it that are willing to try it if someone like you or I would say, hey, this works or doesn't work, or maybe this cream works or some oils. And so there's some other things you can see. I won't go over all of them, but what patient perceptions are. Essentially, green, blue, and yellow are people that are willing to at least consider it. And you can see most of this is biased towards being able to consider. And many people think that it should be legalized for medicinal use as well as recreational use. So what do the studies say? Again, I can't go over everything, but I think the big picture, most of them are database studies. With those database studies, you can't really tweak out, well, did the patient have other comorbidities? Were they using cocaine? Were they using a bunch of other drugs? Were they using a lot of narcotics? How much were they using? And so there are certainly some limitations, but it sheds some light. I think a lot of the studies would say there's potentially harmful effects. But again, I would argue there's some polypharmacy involved, some different types of drugs and medications that may be used with the marijuana. So also maybe an increased risk of DVT. This just came out in JOA this year, potentially that VTE might be increased as well as readmission rates with anyone using cannabis. Again, not a clean study. I give the authors full credit for doing their best with the available data. We went back and looked at some of our data here. It's 71 patients. I get it. It's not a huge study. But what I did is I took out any drug use, any narcotic use, smokers, and all those risk factors that can contribute. And I had a matched cohort of 71 total knees. And I didn't find any difference. We personally haven't seen any differences in our practices with regards to readmissions in this patient population, at least from this cohort that we've used. Our knee society scores were the same, and so was basically our range of motion and all the follow-up. So this is 1 or 2 year follow-up. Again, longer follow-ups needed, but it kind of sheds some light that, hey, maybe it's not as bad as we think. Maybe it can be used as in conjunction with some of our other medications. This study is recently submitted to JOA. It's a prospective study. We let people use marijuana. I did not give marijuana to these patients, so they could do whatever they want. Remember, all the things they're using are different. They could smoke, they could rub oil. It doesn't really matter, some sort of marijuana. I didn't find any differences with preoperative opioid use, duration of opioid use postoperatively, persistent opioid users. And it turned out to be no differences with anything. So my personal opinion was those patients may require more, but the morphine equivalents in the hospital and outside of the hospital didn't show that. And interestingly, if you look here, look at the variance. And that's one of the things I write in the studies. You have these people coming in with testimonials, but I mean, people are doing different things with them, this substance, whether it's smoke or edibles or a combination. This person had 37.6 inhalations of a marijuana joint per day after a joint replacement, which I don't know how that's possible, but someone manages to do it. But I think the bottom line is you can see a lot of variance here, which makes this extremely hard to study, particularly in a database study. So what are the problems? It's a Schedule I medication, a Schedule I drug. So your state may say it's legal, but the federal law is saying it's a Schedule I drug, which is a big problem. So they still think there's potential for abuse. So I can't take a patient and say, hey, here's marijuana for use. I could lose my Medicare participation status, which puts us in a little bit of a bind with how to recommend and what to do. And I would argue a lot of these studies are all chronic pain, and we really need to look at acute pain, which we've tried to do the best of our ability in my practice, but not in a prospective randomized fashion. And I know Bill's on this call, Hamilton, and I really got to thank him because I started coming out with these studies, and we were at AUKUS it'd be 2 years ago, and he said, Jason, you really need to be the person to do the prospective randomized study. And I tried to explain how hard it is. And he looked at me and he said, you need to do it. And so Bill, I really thank you. It took me a while. I went through the FDA. I got an FDA exemption to actually study synthetic marijuana. If it wasn't for COVID, I would have started back in February or March. I was set to start. I had 2 research assistants leave, one for medical school, one for nursing. I hired 2 more because I need 1 full-time person. I'm training her up. So next month, I'm going to be starting this. It's a prospective randomized study, synthetic marijuana. It's Marinol. So I get it. You can argue the CBD is not in it, but you got to start somewhere. This is the THC portion, and we're going to look at the THC so we're giving them the pills in the hospital. We send them home with 2 weeks of the pills. They're the same bottle, and I have our pharmacy making sugar pills. So I think it's going to be fantastic. I think it's going to at least answer the question, can we decrease opioid use? Is it safe? And, this is going to take a few years. I think we need, I can't remember my statistical powers, but it's about 150 I need in each group and for the prospective randomized, but we're going to be checking at 50, 75, 100 to make sure safety and things. So I'm hoping to have a little bit more data for you, maybe next year, at least preliminary data. And again, I really have to thank Bill because he kind of forced me into it and said, if someone else do it, you'll kick yourself in the butt forever. So, in conclusion, I think you need to understand the law. We all want to limit opioid use. I think that's really important. It depends who tells the story. I don't think there's a beneficial adverse effect in the literature based on what I've seen, but certainly you could read one way or the other. But there certainly needs to be more research, and I hope that my practice can shed some light on that for everyone here the next year or two with our studies. Thanks for the time. And by the way, I do more than just look at marijuana. I promise I do operate. If you hear my talk, I do marijuana talks. I do knee and hip replacements and partial knees and revisions and stuff. So it's not all just marijuana in Colorado. Thanks, guys.
Hard to believe, Jason, but thanks for that insight. So we're going to move on to another way potentially of avoiding the use of opioids. Presley Swann, also in the Denver, Colorado area, looking at it with a little different perspective. Go ahead.
Hey, thank you, Chris. I'd like to say every time I have a patient in Denver that wants marijuana, I just send them to Jason. As far as disclosures, you can see none of these are pertinent. I actually am using a different indwelling device than Avanos now, so not pertinent to this talk. We all know in hearing Jason's talk, Hurst earlier, that and Bradbury, that opioid use is a big focus of our profession moving forward. I think it's incumbent upon us to understand that when a patient comes in, that there's a risk for them to be a lifelong user, and these rates of them already being on stuff from PCPs is staggering. But really, we know that within 10 days supply, there's a 1 in 5 chance of being a long-term user. And as we continue that script when they come in, that the longer we refill that or acquiesce to a patient's request, the more likelihood that they are going to be calling into your office asking for more refills. So where did this start for me? Outpatient arthroplasty was really what I was trying to hone in on. The number 1 in 4 reasons why people readmit after a joint replacement really doesn't have anything to do, as Keith Berend showed, to a huge medical complication from your surgery. It's due to the other things like nausea, vomiting, urinary retention. And in fact, most patients want to avoid narcotics if they can, and want to go home if they can when you educate them on how you're going to do it safely. And so we all have different components. Really, it's all very similar. The biggest thing I am an advocate for is regional anesthesia, both from blocks from a hip perspective and a knee perspective, so that you're getting the blockade from above and not just giving them medication. And this is a study done when I was a resident. Really, it shows the difference of just narcotics alone plus scheduled medications and adding the blockade over that first 3 days. And none of us know how long patients need to have the block working or have decreased pain. But I think in general that at around 3 to 4 days, if you can get patients through the worst of the first 48 hours, then it should be a pretty easy transition to Tylenol and some Ultram. And so what's the better block? There's been a lot of different surgeons that give evidence of how things work in their practice. And I actually do respect that, because literature is literature and things don't work as well and maybe in your hands as what a paper would show. I have partners that still use liposomal bupivacaine despite really clear evidence, but they do have great outcomes looking at their registry that we have in a supergroup. We know that ropivacaine is really no different than a liposomal bupivacaine. We know that we've reverted back to putting Toradol and clonidine, et cetera, in these cocktails. And based on Chet Ranawat's original paper, we still don't have a magic solution to no pain after a knee replacement. And then it was studied whether continuous versus single shot adductor canal block for a knee is safe from an ambulation standpoint, and that was found to be safe. And so there was a level 1 study looking at single shot versus continuous, and continuous was found to be superior because we all know that if you do a single shot adductor canal block, that it will wear off sometime in the early waking hours or by noon the next day at maximum. And then the patient has kind of a pain crisis. And so what are you going to do to transition them from that? And that's where I moved my practice. And so a single shot adductor canal block compared to a continuous, this is my own research and looking at patients, but really the morphine equivalence and the continuous was 10-fold less than doing a single shot when you have this cliff effect when patients say, I'm in a ton of pain. And there was a recent journal article that looked at revision knee replacement compared to primary. And really, if the blocks are the same, the treatment's the same from a pain standpoint. And you can see in the bottom right slide, this is a case I did in an ASC because they reimbursed the implant cost. But he had a broken hinge from outside institution, and he had a continuous adductor canal block and went home the same day. So these aren't just chip shot cases as far as which block to do. And so then as a surgeon, which I completely understand, does it delay your time in the OR? Does it make your day longer? And I found a workaround around that. When you don't quite trust your anesthesiologist, who shows up each day is variable. And I kind of took that back into my own hands so that I had a consistent effect from the block. So this is a video of a partial knee replacement. So what you can't, it's hard to tell, but I'm threading in an introducer needle that then introduces the catheter into the knee joint from the synovium, which is a little split I make with a bovie. But then I take a pituitary rongeur and grab the catheter and drive it up medial next to the femoral in that adductor space. And then I take a vicryl and close down that retinaculum. So there's potentially flow that could come back into the knee, but I do push at least 10 cc's in to confirm that there's no backflow into the knee joint itself. And that makes sure that the catheter, both from an infection risk and potential local toxicity if you're doing a partial knee replacement, doesn't cause chondrolysis. And this is, as you can see, is done while the cement's curing and you're not having to wait on anesthesia pre-op or post-op to turn over the case to do a block if the anesthesiologist that you're working with is not comfortable with that. And really, these videos is a continuum of care of a patient. This is 2 hours after surgery on the far left, having minimal pain, full extension of her knee. She's dressed and ready to go from the PACU. I think this was 4 years ago when I first started doing this. So this isn't new to anybody. And again, credit to the guys that did it first with, joint implant surgeons, Chicago, et cetera, because we learn from everyone what works in each clinic and surgeon. This is a patient in the next video. She's 2 weeks out. She never took more than Tylenol, which in a retrospective review of my own patients, in an opioid naive patient, i.e. they didn't come in on Percocet or oxycodone, that only 73% of them really took more than a couple doses of oxycodone. And really that's out of fear that when the block wears out, that they go ahead and take it because they're worried about pain that comes. And really, that's the number one concern of patients, is the fear of the pain after surgery. And so if you can address that, it sets you up for success. One of the things I'd like to add is, as this is predominantly knee talk, is that I have been adding QL blocks for hip replacements and PAOs or hip scopes that I'm doing. I was doing lumbar plexus, both single shot and continuous. And based on a fellow that has now worked with me at Porter in Denver, the QLs are very quick to do. The patients have very little motor, quad weakness, etc., like you get from an FI block. So it's a pretty drastic practice shift I've had in my own practice. I'm a big believer in regional blocks, as long as the anesthesiologist that you work with is doing them well and efficient, so it's not a delay to the OR. Again, thank you for your time. These are my kids. Thanks for the panel and having me. Again, I always learn from everybody's talks every year and pick little things up that impacts our patient care and makes our life better.
Thanks, Presley. Great talk. We're a few minutes behind, as is expected, with a lot of great content in each of these talks. Bill, is it time to start using pharmacogenetic testing, or should we wait for a little more studies?
I don't think it's ready for prime time yet. There's a couple big hurdles. One is it's expensive still. It's not widely available, so the current test I'm using is $200 a patient. You'll occasionally have people who walk in with this. So I think for physicians to be aware of it is a good thing. So hey, listen, I know what this is. I'm familiar with it. And then you can take the report and read it and have some idea as to what's going on. Most importantly, we just don't know yet if someone has one of these genetic variables and we change the medicines, does it make a big difference with regards to care? So is there going to be wide applicability here? I don't know, but I do know that there are these patients, when you give them these pain medicines, it just doesn't work, or they have these wild side effects. And I think this is one potential explanation.
Thanks, Bill. Presley, I think many of us would agree that if we can find ways to do regional anesthesia and avoid the use of narcotics, we ought to do that. It prevents the original pain insult. It prevents the brain's response. It prevents their need to take narcotics during surgery, and therefore their exposure and lack thereof naive state and the postoperative period, and therefore the sort of cyclical nature of it. Many people, I think, would be skeptical or leery of the things that you kind of got to: chondrolysis and partials, infection risk, the cost, the indwelling nature, tethering a patient with something when we're moving away from getting them tethered to things in general. So how do you address that? In my own practice, I still like regional anesthesia, but I'd rather do a single shot.
Yeah, these are all great points that, I've been tracking personally. I haven't noticed an increase in infection risk and catheter sites. You do have issues with pull out or leaking catheters, which is a separate headache. So that, to say that this works perfect every time is not true. That's 70% of the time it works every time. I do think it works better than a single shot or a local infiltrative technique with either a regular cocktail or liposomal bupivacaine. And for me, the trade-offs of doing it, of having those patients with the bag of the block, which is filled when they go home, with the issues of the phone calls, it generates maybe 20 phone calls a year. For me, that trade-off is pretty good compared to, I'm in pain, I think I'm going to go to the ER. When you're doing outpatient arthroplasty, as far as infection goes, I've had last 2 years, maybe 2 native or after primary knee or uni infections. And so that I haven't seen that. It's definitely a concern. I just personally haven't seen it. When you look at other surgeons that have utilized that in my super group, We currently have, I think, 12 joint surgeons now copying this protocol. They haven't seen an uptick over the last 2 years in infections either. As far as chondrolysis goes, definitely an issue or concern. You just have to pay attention that there's not some sort of way for the bupivacaine or local anesthetic to backfill into the joint.
Well, importantly, this is Keith. Importantly, the Oxford group for 20 years put an intra-articular indwelling catheter in after an Oxford, and they've got 97.4% survivorship at 10 years. So I'm not sure that whole chondrolysis thing, that all came from the shoulder. That was all, there's no data in the knee that has ever suggested that's an issue. That was all shoulder issue. It was with one particular device. And so I think what you're doing is fantastic.
Thanks.
Well, thanks, Keith. I learned from you. I mean, I've been out to visit y'all, and again, you can learn from each other. I've copied a lot of things y'all do.
All right, let's move on to the next session. Thanks everybody for that great discussion on how to avoid or decrease at least the use of opioids. We're going to move as quickly as we can, try to catch up, and I am actually giving the next talk, so I'm going to do my very best to do so. We're going to talk about creating value in an academic environment. Some of us on the call are academic surgeons, some of us are in private practice, some of the participants are in academics, and many are in private practice. No disclosure is really relevant to this topic. We have obstacles in academics to create value. We're a big center. It's costly. There's different contracts with payers that might pay us a little additional. We have some bloat in the system, whether it's layers of trainees, whether it's sort of inefficiencies that are inherent to academia. I think that the quality and the outcomes are as good in many cases as in any other setting. But institutionally, from a perspective, there's not a lot of care about the surgeon, the physician, or even the group, but rather the system. And that's a very common finding in most large academic and even large private centers at this time. With us in particular, we had very little investment in infrastructure or programmatic development, and oftentimes we would be asking for help to make improvements and begging them to show us the money. We have residents and fellows. The positives are they help us care for patients. The negatives are they can be a transient workforce, which adds potentials for variability. Variability can lead to inefficiencies and excess cost and opportunities for quality to suffer. On call, the default answer for most residents or trainees is, if you're worried, please go to the emergency department. When we entered the bundle, and even now subsequent to that, we know that if a patient goes to the emergency department, there's increased costs and there's increased likelihood for readmission and other complications that can ensue, unnecessary treatment. So the avoidance of that is really important. We at the University of Utah have an orthopedic hospital and a main hospital. We have a constant lack of access to resources such as ORs, bed space, personnel, and are constantly told there's not enough time to do the cases we want to do. We started working on a new concept called perfect care using a new tool that we developed that was in contrast to the TDABC concept from Harvard at the time. And it was a unique development because we defined the elements of perfect care and not bureaucrats or administrators. So we watched this over time, and the thing that we showed and was really helpful to show administration, and we gave it to everybody, is that we were able to, by defining certain things, by measuring a measurable change, and we could make change when we could measure the opportunity, we showed improvement, lowering of the cost by 40%, and it continued to decrease in that red line below. The downsides of our earlier experiences, but we were successful. So we did all this before going into the bundle. And so we showed a lowering of our baseline cost in our historical analysis for entering into BPCI. So that's bad because BPCI, you were advantaged by being really costly beforehand and saving a lot of costs going into it. But we were successful. We got academic productivity. We were the poster child for the organization. They put us on the front of the, we put us in JAMA. They put us on front of the Salt Lake Tribune. And we started getting buy-in from administration, which was really important for getting a sort of investment into what we needed to be successful. So they stopped saying, we won't give you any money. And they started saying, well, here, we can start investing a little bit of what we've been saving back into your system. We also learned from those before us. We aren't trying to reinvent the wheel when doing all these things. Richie Orio and Bosco and Lowry Barnes, they're all doing really important things and publishing on this before we ever started doing it. And that's the case with most of the things all of us have been talking about tonight. None of the things that we've been presenting are really sort of novelly invented by any one of the presenters, but rather sort of using those things that people around us have been doing. As Keith mentioned, even in the ASC world, Rich Berger's been doing it before us. And we've all learned from those that have come before us. I think that's really important. We don't have to be isolated in silos. So we went into BPCI, and even with that, we followed the leaders before us. We decreased the utilization of post-acute care. We saved the hospital a ton of money. In the 2 years, they got $2.9 million back when they took the target price to the actual Medicare cost. They give you the sort of incentive back. And that was a very successful initiative for us. With that, again, a continued buy-in. We started getting opportunities for gain sharing. It wasn't always professional gain sharing to the individual surgeon, but to our department, to our division, reinvestment, and a coffer fund set aside for later programmatic development. We continue to do ongoing work. We have a dedicated joint pool. We pay our PAs and fellows to take call instead of having our junior residents take call when they haven't even done a joint service rotation. Any of our providers are willing to see patients the next day in clinic to avoid a patient going to the emergency department in the middle of the night. We've shifted to outpatient. COVID certainly has helped drive this. We were 9.8% in 2019. 72% of patients are going home same day surgery and not a 23-hour or overnight stay. This is not related to the inpatient only list. This is related to not having patients admitted to the hospital. We do not have an ambulatory surgical center with physician ownership. We do have an orthopedic surgical center that is mostly catered to our sports surgeons, shoulder surgeons, foot and ankle and hand surgeons. They allow us to do a few cases over there, but our block time's really at the main. So we took the space and said, we're going to change the paradigm and send people home through same day surgery. And it's been very successful. 96% successful to launch on the day of surgery with very few readmits. We've avoided issues related in value creating in an academic environment to restricted vendor contracts or restricting physician opportunities for selection of their desired implants or technologies of choice, and instead use cap price points as our methodology. There's value that's created to an industry that would like to have you provide them a volume requirement to give you a discounted price, and they get an access to trainees that might go out and use their products. And so we look at ourselves as providing value back to them, and without providing them a volume agreement, we can still allow the ability to do comparative research, to do the best implant for that patient based on the conditions that might exist, and other reasons that we choose to do this. The hospital at hotel program is getting, destination care patients that otherwise might stay in a hospital bed for convenience, out to a hotel room with nursing from the community to meet them with home health care at the hotel that night. And that way they can launch back and go on their 8-hour drive or flight back home the next day. And then gain sharing on new value initiatives. When we come to the hospital, they're actually willing to give us a cut of the pie when we can provide value to the system. Lessons learned, physician engagement works better than top-down administrative forcing of change. Don't try to reinvent the wheel, learn from those before you. And gain sharing at an academic institution might not always be cutting a check to take home, to your retirement or to your own personal investment at the end of the day. Sometimes it's reinvesting in the system, and that to us was really helpful, whether it's research coordinators or assistants, it's getting another PA, it's getting another nurse coordinator. The hospital's not always willing to just hand that money over, and by being successful, they give us buy-in and they start to reinvest in our system. Yeah, so thank you. So that's how we've tried to work in the academic environment and creating value. It's not always easy. Dr. Bolognesi is going to give us a really important, I think, next discussion. This is, I think, is going to be the highlight of our AUKUS meeting coming up in the next month. Talking about, lessons from the Hill. There's a lot of change in health policy, CMS, and Mike, I can't wait to hear from what you got to say. Thanks, Bolo.
Hey, thanks, Chris. Your talk's a good lead in for this, because the work you guys did around value that you outlined at Utah, I think is, I'm going to maybe try to show you maybe how government actually perceives that or has responded, and the things that groups like AUKUS are trying to do to really recognize the value provided, whether it's in an outpatient center like Mike and Keith and Jason and Mike Morris, or if you work somewhere like Utah where you do. So these are my disclosures. I think the only relevant issue is position I've served on the board for ACUS for several years and continue to serve currently. And, really wanted to focus on was just the advocacy efforts of ACUS around specifically reimbursement around our hip and knee codes. So our main primary codes and sort of that story, because I think it's an interesting story. So the RUC, just to give you a quick interview, and you say, well, what's the RUC? The RUC is basically the group which really helps decide how we're paid, for the procedural portion of how we're paid for any specific code. And this creates relative value units. And these codes are often reviewed over the years, but that's sort of what creates the actual amount of money you may get for a hip or knee replacement. And it's a somewhat confusing process. And I guess I may try to propose by the end of this short talk, archaic in nature. Our codes have been reviewed before. The last time with maybe significant relevance was in 2013, and there was a proposal to drop these values fairly significantly from a percentage standpoint. And the numbers are listed here about sort of what the values were in 2013 and what the RUC was recommending, which is really a drop to 19.6 for hip and knee from larger numbers of 23.25 and 21.79 for knee and hip respectively. And this was thwarted by the actions of many for sure, and great efforts and us coming together to sort of prove our value. And it was successful to sort of maintain where we were. And unfortunately, we're sort of under the gun again and have been since 2018. And our current value for hip and knee is 20.72. And that again generates what you sort of get paid. And remember, the RUC or CMS really only has, a certain amount of money, and they have to sort of find ways to cut the one piece of sort of the big pie into little pieces of pie to make it work. And they've proposed again to cut us to 19.62. And we're in the comment period relative to the final rule. And the work is ongoing from ACUS just to try to sort of thwart this with meetings as recently as a week ago. Honestly, with CMS that I was involved with and others, and HHS, in fact, the Deputy Secretary Hargan, and the OMB branch of the White House. So this is ongoing. I promise we're trying. But the story and what I really want to hammer home and really sort of finish with about is how we got here. There was an anonymous sort of proposal to review our codes. I went to CMS outside of the normal comment period. Basically, this came out in the proposed rule, but the source was not disclosed. I'll break the secret and tell you the source, not surprisingly, was one of the largest insurance providers in the country or world for that matter. They basically said our codes needed to be cut because of the total operative time. The data that they used to make this argument was based on a study from the Urban Institute. It was a study paid for by CMS. And basically you see the total number of cases there under Urban Institute, a little over 1,000 cases, trying to say that we had dropped 15 minutes or so and therefore should have lost that percentage of our reimbursement. We really were aggressive, and we fought this with publications from folks, some of which I think are on this faculty, if not tonight or previously, showing that the work is still there, particularly around the total operative time. And that was not just peer-reviewed data, but we proved that when we were surveyed. Despite the fact we said we need a value-based care survey, they did not give us that. Our survey was robustly responded to, a great response of actually 206, which sounds bad, but it's much higher than others. And really our survey, the way we surveyed, we really should say if you took the 25th percentile or the median, we're well above what even we're currently getting now based on the service done. And the reality, and this is where it ties into Chris and optimization from the previous talks, is the work we do is really cannot be sort of gathered or fully quantitated by the RUC process, because we can't get credit for what we do for optimization and what we call pre-service work. And basically, that's our argument. And it's interesting, despite the fact that they can't pay us for it, CMS wants us to help them figure out how to justify the work. Meaning they're asking us how to capture that preoperative work that their process, right, their RUC process actually can't account for. And so in short, our answer is, well, just don't cut us because you can't figure out how to fix it. And that's how we're trying to maintain folks. So we do the work, right? We've embraced value-based care and bundled programs. We surveyed and we proved the data that we do the work. Our operative times, we proved that didn't decrease. We do the optimization work that justifies the payment. If they devalue our services, it's going to send a clear message to everyone else that's going to go into value-based care. And we've told them that. We made it clear to them, if you want to keep putting people into bundles, they're going to know what happened to the hip and knee surgeons and what their sort of award was for doing that. And it's pretty clear the RUC process and methodology can't accommodate or account for all the work that you heard about already during this session. Basically, any more good news? Yeah, there's this effort to sort of completely decrease the conversion factor, which would be a cut upon what we sort of get paid for the procedure, as I mentioned. So that's really would be unacceptable. I don't mention the IPO list negatively because we've seen outpatient arthroplasty works. But what I would say is that there's administrative burden to this. And the reality is it needs to be rolled out in a more efficient and more appropriate way than it was with total knee. So this is going to be on our colleagues soon. And we know how to deal with it, but we would make the recommendation that we branch away from it and certainly avoid it and try to make the argument that to at least keep us whole and maybe actually pay us for the work we've done to add value to care. Thank you guys so much.
That's a great talk, Bolo. This is the most important thing that we have on our agenda right now. So we are actually at the Park City Hip and Knee Symposium currently. We're in Park City, Utah. I actually live here in Park City. None of you guys could attend because of COVID, and it's an absolute travesty. I'm going to walk out to my front yard right now because we have some visitors that are worth seeing. This is probably the most dangerous combination of animals that actually we can find in North America. But that's a mama moose and her calf literally standing in my front yard.
Oh, shit.
Eating the leaves off of my aspen trees. So that's how we do it in Park City. And that's what I'm watching out my window as we're sitting here talking about how to do joint replacement on our patients. So anyway, I thought I'd just take that brief interlude for a little entertainment. That actually works into our program because our next speaker was unable to make it tonight. So we're going to move to our final speaker of the evening, going back out to the joint implant surgeons and their expertise in practice management, and Jason Hurst with our next topic.
All right. Well, now that I'm going to talk about OR efficiency, listening to Bolo's talk, maybe I should talk about how to slow the procedure down. Or maybe if you look at this from the other side of the lens, maybe we look at it as not being paid by our CPTs, but by the DRGs from the centers of which we own. So that's where I'm going to talk from that perspective. And like I said before, I think that revenue is very just in reimbursing the physicians that take the lion's share of the burden and the risk in what we do as surgeons. And it's not just what we do in the OR, it's everything that happens outside the OR is where I think we're really paid for. Here's my disclosure slide. So obviously we all want to get done, and we want to get done fast, and we want to get out of there, and we want to do it safely and quickly. And it's really not just our surgeon skill. There's a lot of things involved in trying to be efficient, from how you plan the surgery, how you utilize the space that you own or that you operate from, how you line out your preferences, the instruments you use, all your protocols, all these things go into trying to get through the case efficiently. And I think one of the biggest, I'm going to go through the things which I think are really big parts that can make the biggest dent in your day to make you efficient. I think the first thing is, we adversarially refer to anesthesia when you're a resident, and I think when you're in practice, they should be your confidant, and you should have the best cooperation with your anesthesia team with ultimate trust. And they have to own that same efficiency mindset, and there has to be that mutual respect because it makes for not only a better day, but a much more efficient encounter with the patient and your surgery performed. I don't believe blocks should be performed any other place than the pre-op area, even including spinals. The OR is for operating, not for placing blocks. They also have to understand the concept of a swing room and how to get that done with the communication between the OR team and the pre-op team. There should be two separate, distinct teams. The second thing is know where your deficiencies are. This dates back to when the hospital zone, Adolph and Keith started our hospital. But this was before the surgery center, and this OR efficiency time stamping. It seems rudimentary, but what you're doing is you're looking at every single encounter from the day the patient walks into the facility to the second that they leave, and every timestamp. If you can just do this process over the course of a few weeks or months, you might notice exactly where you're deficient and how to, you know where you're losing time and where you can actually be made better in terms of your performance. And then I did mention that surgeon skill. I think, you know, you have to be good at what you're doing. You have to be efficient. You have to get through it without wasted steps. And I think that this is a great definition in that, you know, efficiency is skillfulness and avoiding wasted time and effort. So getting the same thing done, the same skill level, but just doing it faster. You know, one thing that has come into play in the past few years, I think a lot of it's been with the advent of the surgery centers. We don't have as much space, is organizing your instrumentation. We don't have the benefit of large storage areas. So having the 7-tray primary knee is just unreasonable. So organizing your instrumentation is huge, and doing that beforehand is really helpful in getting the data to move along. Moving to single tray instrumentation has revolutionized our center. This is definitely a plug for TJO because the Classic One system is awesome, and not just I don't believe it. I think it's more from the side of the scrub. When they only have to use 1 tray to perform a total knee, where other systems have 6 to 7, it's a tremendous benefit in terms of flipping that room and actually just utilizing those instruments during the case. It's only coming out of 1 tray. A lot of other systems are trying to do this. I think TJO built their system around this concept, and this should be available very, very soon. It was lighter, intuitive, it's easier to handle, it's cohesive, it's multi-use, that every single instrument has multiple uses. That's a novel concept in the time when you used to have 6 trays to do a total knee replacement. And so what if you don't have a system that's already streamlined, and how can you still perform it? We just got to break your trays down. This is what we did with the Biomet Vanguard system that we're using. We actually took it apart and peel packed everything so that we were just opening a basic type tray and then opening them up as they're going along in sizes. And this is not just, this is agnostic. You can do this with any system. And this allows you to have a small back table, easy to open up, easy to go through the case. And the only problem though is that this does involve more of the OR staff to open things up, which may potentially open up room for contamination. But 1 tray would be ideal. But if you need to do it, or if you only have a system that has 6 trays, breaking it down like this is really helpful. That's what we did when we first started our center, and it's been awesome. It saves a lot of space as well. If you just have that kind of mini bar type rack, you can get through it. You can store it much easier. Just to summarize, I think some of the most impactful tenets on getting through your day efficiently is on-time OR entry, and that is that good relationship with anesthesia. You want to get that patient prepared rapidly, and you got to be cooperative with anesthesia so they're on board with getting this stuff done in pre-op and getting them in the OR. You have to be efficient at what you are doing as a surgeon. Don't waste steps, and you have to teach your scrub staff and involve them in the case in terms of being knowledgeable at every single step. I think instrumentation takes you to another level. I think an intuitive and streamlined instrumentation is huge. Whether you make it on your own or you have a system like the Classic One tray, I think that is somewhat of a game changer. And then you got to flip the room, and that comes into play with a staff that is on the same mentality as you are in terms of getting done, and then having an anesthesia staff that understands that swing room concept, and a pre-op team and an OR team that's always in constant communication. So there's no breakdown in that, and you can keep the day moving along and get as many cases done in your center as possible. Thanks.
Jason, great talk. I tried to answer at least one of the questions with way too many words and typing to Andy about how to create value in academics and do outpatients without doing it in a surgical center. I hope that was helpful. Bolo, my question to you is, how do we make a difference here? We can start changing the way we fill out these silly surveys that they send out perhaps, but it's really uncomfortable getting involved in the political space, actually. We all think that we can make a difference if we contact our local senator or congressman, but many of us don't know them very well, and it's not really our forte. How do we help the system? How do we help ourselves?
Yeah, it's probably multiple things. From an academic standpoint, Chris, it's continuing to publish on the work done around optimization. The biggest flaw in the work you guys do, like what you really outlined, the things you do to add value to the care, whether it was in bundle participation or even stuff you do go forward, because what will help us in the longer term, when I say us, everybody, is to be able to justify the pre-service time. That's where we're really stymied with the ruck stuff, is because the ruck stuff was created, it's archaic. It was created well before there's any concept about what you do to get somebody ready for surgery, or even the touches afterward, like you heard Bill Hamilton talk about, and what you do running a platform for interactive care of the patient post-operatively. We need to be able to publish, show efficacy for that, because when we go, you don't have to be the guy or the lady to go, but when we go there, it's great to have that data, because that can be used as extant data, that's the terminology for it, to make the arguments with the RUC and CMS. So that's the RUC CMS side. If you don't want to go to the hill and do that interaction, I understand. I think you get used to doing it. The other time is, when asked by groups and to support certain people, not like picking sides of, Republican or Democrat, but if you identify someone that appears to be, if AUKUS or AOS identifies somebody that needs some help, that's likely to be an ally for our stuff, that's where you might think about some of your, I'm not saying anybody specific, but financial contributions to help those folks. They need it. They can't stay in office. A lot of what these guys and ladies do to stay in the office is a lot of work around fundraising. It never stops. It's almost one of the major things they do. And again, that data around optimization, that's where we've sort of have made the most ground, because they don't have a great answer, right? They've already formally said in the proposed rule that they recognize that work occurs. They've never recognized it before. So that's our hope long term.
Yeah, I think that's absolutely imperative. I just kind of, in my answer to Andy's question, highlighted about 1,000 things that we tried to do in an academic environment, and we actually didn't hire any additional resources or add any FTE or anything like that. They gave us no more money just because COVID started. In fact, if anything, they were telling us, if you think you're going to get any extra money from us, you're joking yourselves. And as a result, we didn't, but we used the things that we were doing before. But it's a ton of work outside of the operating room. It is all of those things that you said. And it's all those things that Jason and Mike and Keith and everybody have said throughout the evening on how we do these things successfully.
Yeah, I think that Keith and Mike and Jason, the fact that they've shown you don't need to be in the hospital and it's safe, that doesn't go against the argument of, what you do. That doesn't hurt the argument with the RUC. Being more efficient and all that. I think those guys and others, here on the group, you're doing work above and beyond what used to be done. We couldn't basically, it's not, everybody is doing stuff that argues for what we do for value, no matter where you're working.
I think one of the really important things is that while all of that is super important and it makes perfect sense, basing our income and basing our worth on what the government suggests our relative value unit and our time spent is completely asinine. And we need to continue to, as we have, whether it's in academics, whether it's in private practice, whether it's in hospital employment, drive the fact that we are in charge. And our value, our relative value, our value to society, our value to our patients is not predicated on what CMS thinks or HSS thinks we have a value in. And the whole point of the RUC dropping our revenue or dropping our income because we spend less time in the operating room or they spend less time in the hospital or less time in the outpatient facility is asinine. And it's a means to an end that needs to stop. And Bolo, I challenge you to stop it.
Okay. Keith, I think you talk about what's been referred to as sort of the nuclear option behind closed doors about sort of what to do. I think at some level you're right. I think I guess I'd say it this way: the RUC process doesn't work for what we've done. When I say we, the collective we, and what we do to make these operations work and help people, and
to help people. That's the most important thing. It's to help people.
Yeah.
And what we're doing helps people more than what the RUC process is evaluating.
Well, that I agree with, for sure. For sure.
Well,
For sure. No, I hear.
We all agree. I think it's time to wrap this up, though, and we all are going to challenge each other to fix this problem. We have to all be advocates for ourselves and for our patients, and take the bull by the horns. Go out, be an advocate, do the fundraising, do the packs, support the people that are up on the hill like Polo and others. We all have to show our worth. So publish the kind of work we're putting into this.
So this is Presley here, Keith and Bolo and Chris. At what point, we have such a powerful voice to see patients every day. At what point do we have almost a super PAC of patients saying, educate them on, we can't, this is non-sustainable to decrease us every few years.
Yeah, Presley, the quick answer about that's what was sort of enacted in 2013, and basically it was enacted around sort of the threat for access for patients to hip and knee arthroplasty, if indeed we were cut. So I'm not going to say that would happen per se again, but I guess I would say that's an approach that was used before, and you could say that maybe that's what helped in 2013. So. You're very insightful. The hill, if it's going to be a CMS, which is a administrative solution, or if it's the hill, which is a legislative solution, two very different solutions. The one where the patient PAC works, of course, is with the legislative solution. And there's a bipartisan letter that supports our position to not be cut. I'm sure you can find it on the ACUS website. But that may be something that has to be resorted to. I hear where you're coming from.
Presley, the only answer is, and I'm not doing it tomorrow by any means. The only answer is the nuclear solution. And we've been driven down. I'm serious. We've been driven down to where we're a commodity, and if it's not me, it's him, and they can go across the street, and the surgeon across the street who's done 7 hip replacements gets paid the same amount that Dr. Morris gets paid for having done tens of thousands or 10,000 hip replacements, gets paid the same amount, regardless of, and then you get into the bundles where they have fictitious measurements of quality to make, risks, and the risks aren't even defined as we've talked about tonight. The only option, if we're going to really do it, is the nuclear option. That is, everybody drops Medicare. And you say, I'm sorry, you don't have a choice. And unless we do that, and until we do that, and until they push us far enough to do it, and what I think is really interesting is the outpatient codes for total hip replacement, which are coming in 2021, are horrible. Right? So the facility fee for outpatient total hip is terrible. And they've done that on purpose. They've done that because if you look at physician-owned hospitals, they drive their patients to be inpatients because they get paid 40% more. 40% more if they're considered an inpatient than an outpatient. And so CMS has directly driven hospitals to force surgeons to keep the patients as an inpatient instead of doing it as an outpatient. We can efficiently do it at the surgery center, making good choices with implants, making good choices with anesthesia, as we've talked about all night. But until we all stand up and say, you cut our reimbursement for doing it as an outpatient, you cut our reimbursement for doing it in general as a surgeon, whether you're academic or not, at some point you got to go, you know what? We're done. And that's where, Bolo, that's where I'm getting back involved, is when we're ready to say I'm done.
That's a great way to wrap it up. I love it. The KRB's back involved. We got a chance.
He's back in town.
Back in town.
For all the panelists and their involvement. Thank you for all the attendees. I hope this has been a beneficial symposium for you. And again, thanks for your attendance. We'll take care, everybody. Stay safe.